Good afternoon. My name is Brian Abel, and I'm one of the co-chairs for the Chronic Disease Action Team of the Healthy St. Mary's Partnership. On behalf of the team, I'm pleased to introduce Dr. Sushant Ranadive. Dr. Ranadive is an occupational therapist by background, and then pursued a master's degree and a PhD in exercise physiology. He worked at the Mayo Clinic as a postdoctoral fellow and then as a research faculty before moving to the University of Maryland College Park. His research investigates different aspects of human physiology with a focus on aging, physiological differences within the heart and vascular system between men and women, and an emphasis on racial differences and health disparities. Additionally, he developed a keen interest in addressing the questions related to physical activity and exercise in preventing and treating chronic diseases. Please welcome Dr. Sushant Ranadive.
Thank you very much for the invitation, and happy to be here talking about the physical activity to prevent and treat chronic diseases. I'm going to take a slightly, if you may, initially a pessimistic approach into suggesting how does physical inactivity hurt us before moving into the physical activity component. And it's not meant from a standpoint of scaring you or putting you like how bad physical inactivity is. But I like to set the stage into showing what does one do if there is physical inactivity involved when we think about chronic diseases by themselves. So the first question we should ask is, why should we even care about this? Yeah, the primary answer is very simple: health. And the second important component of this would be economics. So we have both the health and the economic component, which is inherently connected to each other. And I'll show you the economics component in a couple of slides. But for today's talk, I'm going to focus a little bit more on the health perspective of this. So here is the data that CDC shows, and this is the map of all of the counties divided within the states, right? And in this case, obesity is defined by body weight or BMI. And there are some nitty-gritties with that issue itself, how we define obesity. But as you could see, we have some data from 2004 all the way up till 2014. We have data beyond that. But this data, CDC had put like a beautiful thing with the map. Until the pandemic hit, if you were to watch this trickle out, it would look like an epidemic by itself spreading. So as you see this, years have passed by from 2004, you could see the counties getting more and more population, which is driven towards obesity. So CDC stopped putting out this kind of mapped data, or probably I'm not able to find the same kind of colored map data on the CDC website. So by 2013, you could see the stark increase from 2004 across the counties in terms of prevalence of obesity in those counties and the population by themselves. So this is again looking at the obesity and national all available years, and we didn't have the map. We don't have the map anymore, but this is from 2011 all the way till 2019. And you could see even at 2011, 27.4% of the population has prevalence of obesity. By the time we get to 2019, we are closer to 31.4. So it might look like a fairly flatter line, but the important thing to notice is that we are not turning back. We are not making it go down. We are, in famous Dr. Fauci's words, we are not flattening the curve in here by any means. It is going up consistently. It is the same thing if you think about diabetes. So any of these chronic diseases follow obesity in terms of, and when I say obesity, as a scientist, as a physiologist, I look at it from visceral adiposity, meaning that the fat cells within the body and not just the body weight by itself. And all of these chronic diseases, may it be diabetes or atherosclerosis, follow the prevalence of obesity to a greater extent, right? And so similarly, as you could see, the lighter boxes, and I like to point out Colorado because it's one of the kind of healthy states. Apart from that, which is lighter, meaning that there's not as much prevalence of diabetes. The darker shades, as you could see in certain areas, suggest that there is more prevalence of a chronic disease like type 2 diabetes across. So this is in 2004. And again, you could watch as the data trickles out through 2004 all the way again up to 2013 or 2014. You could see the diagnosis or the prevalence of diabetes go up exponentially one more time. So all of this is suggesting that we are not slowing down in any form or shape in terms of chronic disease. So I had promised you that I would show you or share with you some of the issues that underline this, even from the economic standpoint. So this is data for Maryland, and we are in this state. So I like to present it from a Maryland standpoint. And if you look at it, this is 19 to 64. So I've just pointed that. And in 2013, our state of Maryland spent $5,850 million on direct or indirect costs. So this is a total annual cost attributable just to diabetes. So it has an economic barrier as well. It has an economic impact as well when we think about physical inactivity and how do these chronic diseases add on apart from the health perspective of it. So when we think of these chronic diseases, a lot of times the first question, that I would get in a class, or I worked in weight management back in Chicago, and the question that comes up is, well, what if I have the genes for it? Like, what if I'm predisposed to it? And I like to show this. It's a really nice figure from a paper from 2011. And what this kind of shows is your relative risk for premature death or disability on the y-axis, as you could see here. And on the x-axis, you see health behaviors, minimal on the left side, optimal on the right side. And you could see that what affects more relative risk of premature death is a lot of things like poverty, sanitation, infectious disease, of course, violence and war. But as you start to make optimal health behaviors or social changes that occur within the society, as they become optimal towards the optimal side, the relative risk of disability or chronic diseases starts to go down. And you could see that the genetic factors is barely a blip in the whole thing. It does not even account for 1.0 increase in relative risk. Only when it gets kind of even at optimal level, it has no bearing on the relative risk. And I'm talking about chronic diseases. There are rare genetic diseases where it will have a higher prevalence. And it's same thing when the health behaviors are minimal because there's so much of other things happening that the genes don't contribute. It's only in this middle section that the genetic factors could contribute a tiny bit. But the moral of the story, kind of the takeaway from it, is that always suggesting, or some of the students who question with the idea that what if it's my genes, that's maybe a fair argument in a very limited number of cases. By and large, as you could see on the optimal side of things out here, when the relative risk is the lowest, when everything is fantastic, your genes contribute to the least minimum in this sense. So we got to think about the genetic part one. The next component, as I had said, your social factors, apart from the genetic, matter a lot as well. So I'm talking about inactivity right now, right? As I had said, we are focused a little bit more on the inactivity component. So when we think about this, look at this data from 2011 and why this matters when we think about inactivity and the prevalence of chronic diseases itself. So this is from King County, data from King County, and you could see that the prevalence of inactivity is the highest in the family or an individual that has the lowest income, versus somebody with the highest income, 75,000 and up, the inactivity is the lowest. And I always tell my grad students or even the students in my class that you got to think about it from one aspect. I used to do a team triathlon. Who can afford a triathlon bike? You need a certain amount of income to be engaged in that level of physical activity. Who can afford registrations for marathon. Who has the time to do marathon kind of a training, right? So we cannot completely always neglect the social factors, the socio-economic factors, right? When we think about physical activity or inactivity, we got to keep those things at the back of the mind or in perspective, in context of when we think about physical activity or inactivity overall. So I mentioned why do we care? In the overview, what I would talk about is what does physical inactivity actually do, right? So I gave you a background of this chronic disease increase, a little bit of the economics, a little bit of the social factors, but importantly, I'm a physiologist by background, so I like to talk about physiology also. What does it do to the human body? What does it do to physiology by itself? So again, CDC brought out this fantastic thing, and this talks about actually physical inactivity. So this is a graph of physical inactivity. Lighter shades, of course, there is less physical inactivity, meaning that those places are highly active. And again, I would like to point out Colorado, beautiful state for being physically active in general. And there are lots of other places where you would find that. But you could see that Colorado, one, it doesn't change as much. You could see a lot of change that occurs all throughout the country, flips back and forth in terms of activity and inactivity. One thing you have to be careful about when you think of survey-based questions is humans love to underreport how much they eat or how much they weigh, and love to overreport how much they exercise or how active they are. Hence, one part is the flipping of back and forth. Second part is there could be public policy changes that happen where there's a bike lane put in or sidewalks that are put in, and that increases the physical activity. So the built environment within a system will matter in terms of this prevalence of physical inactivity. And that is why you see some of the back and forth flips between the counties. So how does this actually hurt? How does physical, or does it even hurt in terms of physical activity? So a few of you might have heard the kind of the saying or the terminology being thrown around, is sitting the new smoking? And there's a caveat to it, right? I like to put in recreational sitting as opposed to just random sitting, because when you're sitting, like right now, I am seated, but because I'm giving a talk, I'm involved, there is a lot of movement that is occurring. I'm a little bit tense. I'm sitting up straight. And so that sitting is very different than just recreationally sitting, binge watching a series or a movie. So the question is, how bad is this sitting, or how bad is inactivity when we think about these chronic diseases or we think about the physiology of it? So let's take a healthy group of individuals. Okay, so they're otherwise healthy, no problems at all. The lighter boxes are people who sit for less amount of time, so 0 to less than 4 hours. And the darker shades are individuals who sit for more than 11 hours a day, equal to or more than 11 hours a day. So when you look at this data, this is deaths per 1,000 persons a year, meaning that higher the number, bad it is. In a healthy person, if you're physically active between 1 minute to 149 minutes a week, and I like to throw in the thing that American College of Sports Medicine, ACSM, suggests you have at least 150 minutes a week of aerobic exercise to be considered physically active. Okay? If you want more health benefits, you got to do 300 minutes per week. So if you're just healthy, no problems at all, and you do bare minimum stuff under the ACSM guidelines, even below the ACSM guidelines, doesn't matter how long you sit, you're just fine. Only when you're sedentary, meaning that you're not doing any sort of physical activity or exercise, does more sitting really trouble you when you're healthy. If you're working out for health benefits, okay, you're pardoned, like your sins are pardoned by physical activity itself, being healthy and exercising. But let's change the dynamic slightly bit here. Let's add the caveat that the person is not healthy. The person already has a chronic disease condition set in, something like diabetes or cardiovascular disease. Now, this equation changes very quickly. Your prevalence of early death or more deaths per thousand starts to go up as soon as you're sitting 11 hours a day or more. Even if you exercise more than 300 minutes a day, but you sit for more than 11 hours, the chances go up exponentially high. I've been trying to convince my mom. My mom watches TV to no end. But her argument to me always is, well, I go for 45 minutes of swim every morning, and then I go for an hour of walk in the evening. Okay, but what do you do in the middle is my question. And usually it's like, oh, I'll watch some TV. Well, she's not watching TV while walking on a treadmill, clearly. So I like to show her this all the time and like to suggest that predisposition or having a chronic disease, if you're not absolutely healthy and you do that level of sitting, you're predisposing yourself to more health risk factors or early mortality by those means. So this graph kind of gives you a perspective that if you're healthy and exercising, great, you could sit, you can enjoy, a lot of things can be pardoned. But if there's a chronic disease that sets in and you do a lot of recreational sitting, now that becomes an issue even if you're exercising for longer periods of time. So I'll show towards the end what interrupted sitting does and things like that. The other part of this is if you think about all of the chronic diseases, the major chronic diseases, so type 2 diabetes, atherosclerosis, which is your heart disease, right, metabolic syndrome, and endocrine disease that leads to any of this, all of them leading to premature death, what you tend to see is the actual cause, and this is a brilliant paper by Dr. Frank Booth talking about physical inactivity. If we think about it as an actual cause, physical inactivity predisposes us to all of these risk factors. Hypertension, most of you know, high blood pressure, right? So that is your high blood pressure. Dyslipidemia is your lipids being high or your cholesterol being high. Hyperglycemia, your glucose having an issue. And visceral obesity, as I had mentioned, right? White adipose tissue around the organs and within the system. Well, if physical inactivity leads to a lot of these risk factors that lead to chronic diseases, you have medications for dyslipidemia, you have medications for hypertension, you have medications for hyperglycemia. The only medicine without a surgery for visceral obesity is typically physical activity or exercise. So one of these risk factors, you need physical activity or exercise to take care of the situation. So you got to be careful as to involving physical activity to take care of these risk factors. And by the way, physical activity or exercise will take care of all of these risk factors at the same time. So you're not taking 3 different medications. You're taking one single dose of exercise as suggested and taking care of these risk factors for the most part. I'm not saying stop your meds. I am saying as a prevention or even as a treatment to a certain extent, physical activity or exercise helps at this level itself. It helps at the level of risk factors itself. So it becomes what was suggested as a primary prevention. So then I like to show what happens with something like type 2 diabetes with exercise and physical activity. So on your y-axis, you have insulin secretion. Insulin is a hormone that is secreted by the body to take care of glucose. On the x-axis is sensitivity. How sensitive is the hormone within the system? And if you could see, if you're active and you're at 0.1, your body is highly sensitive to insulin. So clearly your body doesn't need as much. The body is sensitive, it needs very little secretion. Well, I become a little more lazy and I start to binge watch, especially during the pandemic. I become a little more sedentary. And now look what happened. The sensitivity of the same hormone dropped, it went backwards. And so now the body has to churn out a lot more of insulin to help control the glucose in the same way. This is double arrow. So I can go back and forth. As soon as I become active, it will increase. I still haven't learned my lesson. And I still sit down and I watch and I become more sedentary and I reach number 3. This is your pre-diabetes. Now the sensitivity is getting lower, But now the body is also burning out. The pancreas are burning out of producing that level of insulin. So guess what? The secretion is starting to drop. But still, this is a double arrow, meaning that I can recover from here to a great extent. I still don't learn my lesson, and I don't change my activity patterns. And then I reach point 4, which is type 2 diabetes at times. Right? And there are other causes. I'm not saying all type 2 diabetes are driven only by physical inactivity. I am saying that generally, if you're considering physical inactivity as a factor, this is how it goes with a chronic disease like type 2 diabetes. And now you reach 4, which is a single arrow, meaning that you could take care of the glucose within the system, or you could manage your diabetes, but you're still at the point where it is a point of no return, like you would be having type 2 diabetes throughout. So the thing to remember with this is it is better to prevent it rather than treat it. It's preventable rather than treatable. That's the way to think about it. The next one I like to show is physical inactivity. A little goes a long way. And this is a study done from 1966 that was done in NASA. They brought in 5 young, healthy men and put them on a 3-week bed rest. So the individuals didn't do anything but had bed rest. 3 weeks later, as you could see, their functional capacity dropped significantly. NASA did, and the researchers did a fantastic part of this, not NASA, but the researchers did eventually, was they brought in the same 5 individuals in 1996. And you could see that 30 years of aging, as the authors concluded, 30 years of aging did not cause as much damage as did 3 weeks of inactivity or bed rest. So every time our body undergoes this bed rest kind of inactivity zones, there is a lot more damage done to the body. So I'll move the thing a little bit towards why do we need to start exercising a little bit more. And if you think that this is a novel concept, think about it again. This is a statement: if we could give every individual the right amount of nourishment and exercise, not too little, not too much, we would have found the safest way to health, right? And we might think that this is, I asked my students, and some of the students would say, oh, this would be 1990s, maybe 1800s. Well, it was 450 BC. Walking is man's best medicine. Same guy. So we have known this for a really long time. We sometimes forget or choose to forget, if you may. But we know that physical activity helps us go through things a very, very better pattern for a long time. So I'll focus next a little bit on physical activity. A little goes a long way. And before we get in that data, I'd like to show this test if you're not familiar. This is a sitting to rising test.
To prepare, get into some comfortable clothes, remove any shoes or socks so your feet are bare. Make sure the space around you is clear. Stand up straight and relax. Step 1, without leaning or holding on to anything, lower yourself into a sitting position on the floor with your legs crossed. Step 2, stand back up. But try to do it without using anything other than your legs. Everyone starts with 10 points. Minus 1 point each time in step 1 or step 2 that you use your hand, your forearm, your knee, side of your leg, or you put your hand on your knee or your thigh. 8 to 10 points means you're doing well.
So as you could see, it's a fairly simple test that most people can do as long as the environment around them is easy or accessible, right, and not dangerous. It's a very simple thing to start off with. And this was a beautiful study that was published in 2014 that showed that if you have 8 to 10 points, meaning that you did not take support, you were able to go down to the floor and come back up, look at the time of years of follow-up with survivors had the highest rate. This is your 8 to 10 points. The lowest was 0 to 3. If you're unable to sit down and get back up, the chances of survival drop down very, very quickly. The survival rate dropped down very, very quickly. And this is in older age population. So this is towards 50, middle to older aged individuals, right? And so what this is saying, this test takes into account the flexibility, takes into account the strength of the legs and the balance in the equation. So there are a lot of simple things that can be assimilated, that can be brought in when we think about physical activity. But this suggests that simple tests like these at home can help out. You don't need to go run on a treadmill and get the max test every single time to know certain risk factors. So the last part is simple changes, that what can we do sitting at home, or what can be done within a society as to avoid these physical inactivity components or increase the physical activity components. I already mentioned to you, this is your very basic structure of American College of Sports Medicine guidelines that suggest 150 minutes per week of aerobic exercise, moderate intensity, 300 minutes per week for greater health benefits, and you got to do at least 2 days a week of muscle strengthening. Now, where I say that things can get tricky is all of this sounds fine, and I see it in a sense of being simple. But the question comes up is, wait a second, now to get this, I need to get to a gym, or I need to buy stuff at home to get 2 days of muscle strengthening. So that is why I think simple changes or simple ideas can help out with taking care of some of these thought processes that we have within ourselves, right? So a student of mine, a graduate student of mine, Sarah Mascone and I, we designed this 5-day home exercise program. And the idea with this was that, and this was during the pandemic, by the way, without going to the gym, the idea is that people have this concept that unless you go to a gym and work out exactly for 45 minutes to an hour, you haven't exercised. Well, what if we break it out into smaller chunks? What if we break it out into these smaller components and spread it out throughout the day? So it's not burdensome, it's time effective, and it breaks our sitting patterns all the time. So the idea here was you have frequency 1, 2, and 3. You could mix and match, take whichever one you want. You have about a 6-hour day. So you take an 8-hour work day, an hour for nice leisurely lunch that you might get, right? And then you're talking with some friends here and there. And so another hour. So you could think about this from a 6-hour standpoint. On our first and fourth hour, pick one of the 5 options. If you're going to do the option 3, then you're fine. You've already gotten 30 to 45 minutes of workout. But if not, pick one of the options. Then for hour 2 and 5, another 0.3, frequency 3 and 6, another. And as you could see, these are not time intensive. These are not exercise intensive. It's 10 push-ups, 5 squats, and 5 lunges. Typically would take you maybe 7 minutes or so. It breaks your sitting pattern. But if you do it on first and fourth hour, do it on second and fifth hour, something else, third and sixth hour, a few people did come up and said, well, this was strenuous. By the time I got to hour 6 and in third or fourth day, I could definitely feel it. Of course, now if you go to the gym and work out 7 days a week, this may not seem like a lot. But if you're just starting out, you're doing it at home, this one definitely helps out a lot more. We could take it a step further and simplify it. And I had put down the quote, walking is man's best medicine. So this was another one that 2 of my other grad students, Emily and Cynthia, helped me develop. And actually they did all of the legwork on this. Was this 11-week plan to get to 10,000 steps a day, right? And the idea was, where do you start on week 1? So all of us have our cell phones, we have Fitbits, one or the other, something to monitor our step count. And the idea was, how do you actually improve? You don't go from day 1 walking maybe 2,000 steps to day 2 walking 10,000 steps, right? We got to have a slow progression. We got to make it a habit. We got to change our times and things like that. And so they designed this 11-week program of sorts where it suggests, doesn't matter where you start, you could start at a higher level. You might be walking 4,700 steps. So you start at week 4, but then you progress all the way down, and they have broken it down by an hour. So how many steps do you need to walk every hour to get to the 10,000 steps, right? And so these are kind of sort of easier stuff that can be done at home to break out the physical inactivity patterns. As I promised, this is a very recent study that has shown that 3 weeks of interrupted sitting, and interrupted sitting could be just getting up, moving around, walking around, has lower fasting glucose and glycemic variability, meaning that it has broken down the whole paradigm of chronic diseases by itself. So more interrupted sitting helps out a lot more. I'd like to spend the last couple of slides on this paradigm shift, and I like to talk about, we might be thinking about the whole system slightly incorrectly. We think of it from fatness perspective or body weight perspective, which is by itself a crazy thing to go about, which is not a good idea to go about. What if we change the paradigm to fitness? And what I like to show is this data. This is overweight, so body weight, unfit individuals, and just keep a lookout on this number. So they have a favors higher mortality at 2.14. So overweight, unfit individuals have a higher mortality or favoring higher mortality at 2.14 as compared to normal weight, fit individuals. What happens when you have overweight, fit individuals? You could see that it drops as close to as normal weight, fit individuals. There's like 0.13, which is negligible in that sense. So they're not at any high risk, even if they're overweight but fit. What happens if you're normal weight but unfit, somebody like me? I teach about all of this, but what if I am unfit and yet I'm normal weight? Actually, I have higher favoring high mortality as compared to even overweight and unfit, as compared to normal weight and fit. So this data kind of pushes us to think about how we think about fitness versus fatness. And we might be better off with a paradigm shift thinking about, are we fit? The question could be, are we fit and not are we fat? Could help us line out some of these changes and move towards the idea of fitness as opposed to focused on the body weight component of it. Because as you could see, somebody could get to normal weight, but is unfit and still favors high mortality. So a fitness question might be a better posed question going forward. And this is, I understand there are limitations with even these studies. These are looking at maybe 10, 15 data points, right? But it might be worth a thought process going through. The last slide I want to throw in is this beautiful work that a couple of other professors within our department are doing, Dr. Shannon Jetty and Dr. Jennifer Roberts, who have adapted this part of Nature RX, like getting exercise within the nature and how that helps out. So if you're ever interested, you could get in touch with them and they could help you understand the program more. But the idea that Dr. Roberts and Dr. Jetty have come up with is the more you get out in nature, the more you exercise within the component and get involved with nature, the better off you are in terms of physical activity. So as I showed you, the home-based exercises, walking-based program, nature-based exercises, these are fairly easier components to get to versus going to a gym, getting a membership, or getting a bunch of equipment at home. Not always feasible, not always possible. Again, the socioeconomic component, not always affordable. So moral of the story that I would like to summarize is physical inactivity drives a lot of physiological changes, and not in a good way, almost always in a bad way. These can be driven by environmental factors, by built environment around you. And again, Dr. Roberts does fantastic work with the built environment component. And then the social factors. And we have to always keep the social factors in place. We cannot leave them out and think only from one side of it. And last part is home-based or simple nature-based physical activity can go a long way rather than just being focused on, can I get a gym membership or can I get equipment? So if you have any questions, I'm more than happy to answer those. I have put down my email address. If you have any other questions or concerns about the talk, happy to take those.
Thank you so much, Dr. Ranadive. If anybody wants to submit a question, you're more than welcome to via the chat functions on YouTube and Facebook right now. I'll kick us off, though. So a question that came to mind for me, as you were talking about that physical inactivity and sitting for 11 plus hours a day, if somebody does have a job that requires an extensive amount of sitting throughout the day, is there a certain amount of time each hour that they should be getting up for to kind of break up that sitting?
That's a great question, actually. And one of the studies that I had shown, I cannot remember the exact slide, but I think it is somewhere between 30 minutes to an hour. If you get towards breaking up every 30 minutes to an hour, it's a better interrupted sitting. So 3 weeks of interrupted sitting, I think every 30 minutes, if you do a 3-minute thing, it helps out a lot more. And I fully understand, like, we sit in a world of Zoom and meetings which are online that you can't just stand up in the middle of a meeting. But every often times that we get a break, just going to the furthermost water fountain to get a bottle of water would be the best way to go about, is what I would say.
Perfect. Thank you. I've definitely noticed since working from home, getting up is a little more complicated because you don't have the excuse of going to talk to a coworker about a project. You have to email them instead. So that's great advice. So everyone knows, since we are on this slide, I will link directly that 11-week kind of walking plan and your 5-day exercise plan directly on our website for anybody that's interested in incorporating those into their lifestyles.
Thank you.
We're just going to give it a couple minutes here to see if anybody sends in a question via one of those platforms. I found it very interesting. I think everybody automatically thinks that you have to make this crazy change right off the bat. So I do really enjoy these kind of plans that work up to kind of a greater change in things rather than trying to make drastic changes.
And I think that is, you brought up a fantastic point, is the word drastic changes is the quintessential, the word in there. Is even with these, like in the 5-day program, when somebody reached out to me and suggested that this was getting harder, and I said, well, drop the hour 6 or drop the hour 5. The idea of, the whole thing of no pain, no gain doesn't work out when you're trying to bring about these smaller changes. If there's pain, and also I am an occupational therapist, so is my wife, our thought always goes to, if there's pain, that means something is off, right? And so even those small changes within your limitations can go a really long way. So I think the small changes help out a lot more than these drastic left turns that people tend to take, because that's hard to keep up for 20 years of your life. But it's fairly easy to go for walks every so often. Versus going to the gym for 20 years it's a really difficult thing to keep up to.
Definitely. So looks like we've had a couple come through. So not a question, but a comment. Zamaria is happy to hear that there are benefits to working out at home. She enjoys working out with YouTube videos instead of going to the gym.
So does my wife. My wife does not listen to what I have to say. She will go on the YouTube videos and follow somebody, which is fantastic. I think whatever works for you, you got to do it. There's no right or wrong in it. Again, as long as you're within the pain-free range, you're doing it the right way, whatever works for you, great.
All right. And I'll do a shameless plug here. We did have that morning yoga session this morning, which the recording is available, and it's all things that you can do from the office. And Lori just had knee surgery about a week ago and was able to kind of modify for herself. So, and then another question come through from Daphne. Can you share the link for the sit-stand test?
I think I literally just picked it off YouTube. So I hope I had the reference to them. I didn't want to steal anything. Yeah, vbfit.com. But I literally Googled it in the YouTube and got the sitting and rising test. I just like to say that there are caveats to this. So be mindful, because if somebody has knee issues, has a recent hip or a knee surgery, you want to be very cautious. And that data doesn't always directly apply. So as a scientist, I want to point out that there are certain limitations to all of these. These are not 100% perfect studies.
Yeah, I have knee issues, and I tried to do it. My camera was off, so I tried to do it as that video was playing. I'm going, I can get down, I cannot get back up.
Yeah, I think knee strengthening is one of the things that tests need. So your knee strength becomes very, very critical component. And to improve knee strength, there's a lot of leg exercise that you got to do, and that is why that test becomes quite interesting. Even though a simple test becomes quite interesting.
Next one coming through from Katie. If you walk 5 to 8 miles in different amounts and chunks every day, does your body get bored?
That's an interesting question. I would assume what Katie is trying to suggest is there your return on investment starts to drop, basically. And I would say actually not, because yes, there is what you call a maintenance. So beyond certain thing, your body just plateaus out. There's only so much awesome that you can be. Beyond that, you cannot be any more awesome, right? But to maintain that awesomeness, you got to keep doing what you're doing. So if you're doing 5 to 8 miles, thumbs up to you. You're like 4 miles above me by a stretch, right? But your body does not get bored. I think your body needs that constant hit to keep going. And there is some beautiful research done by a very senior professor in our department, Dr. James Hagberg, when he was a postdoc, about glucose clearance and how often do you need to get hit by physical activity to keep up the body. So I would say if you're doing that, no, your body is not getting bored. The body is going to thank you for your awesomeness, is all I would say.
Perfect. And we'll give it just a second here, just in case anybody has any last second questions. We are coming up on the close of our time this morning. All right, Brian, if you wanted to send us out, I don't have anything else coming through. Oop, you are muted. The phrase of the year.
I very much want to thank Dr. Ranadive for a great presentation, including having us make some paradigm shifts between fitness and fatness and all of the concerns with sitting. So thank you very much.
Thank you very much.
Okay, I'd encourage everyone to take a quick break and walk around a little bit, and then at 2:00 we will come back for the next session of our Healthy St. Mary's Partnership meeting, and that will be with Matilda Jones, whose topic is ACE interface, understanding neuroscience, epigenetics, adverse childhood experiences, and resilience, NEAR. So we hope to see everyone back on online on the YouTube or Facebook platforms at 2:00.
Thanks so much, everyone.
Thank you.